Well, good morning, everybody, and welcome to this morning's session. This is a session entitled Lifetime Management with Self-Expanding Valve based on the latest evidence. My name is David Muller. I'm from Australia. My co-chair is Dr. Yamamoto, and we have an esteemed panel of discussants, Drs. Walton, Watanabe, and Yamasaki. The session objectives for today are as follows: to understand the clinical evidence supporting the Evolut system and its role in achieving long-term valve durability, to explore the benefits and considerations of using the Evolut valve for TAV-in-SAV procedures, to understand the importance of valve design in optimizing patient outcomes and procedural success, and to discuss the significance of first valve selection and commissure and coronary alignment. We have about, I think, an hour and a half, and we have 4 distinguished speakers. Before we do that, do you want to?
Yeah, okay. So first of all, thank you for coming, all of you. And I'd like to introduce this system. This is a microphone. And if you have any questions or feedback, please, like this. And yes, I receive it. And please continue the interaction, and any feedbacks are welcome. So please enjoy this session. Please.
We'll have some microphones, I'm sure, for the audience. So please either ask them on the interactive system, or you can just stand and ask a question. So we'll move on first to the first presentation, Dr. Yoshi Kaneko, latest evidence of Evolut and the journey to long-term durability. Yoshi.
Thank you very much. I have the exciting opportunity to talk about data, which is the most thrilling part of this session, I would say. But I'll start off with some of the latest evidence and really relate it to the long-term durability of the valve itself. So these are my disclosures. The prevalence of small annuli, this will lead to the SMART trial, but especially in the Asian country, probably much more higher. But based on the registry data, it's relatively high. In the Asia, all the way to the left, 59% of the patients had small annulus. This is defined by less than 23 millimeters. And even in the US, 35% of the patients had small annuli. So what do we do in these patients? Also, there has been some data suggesting superior hemodynamics with self-expanding valve compared to balloon expandable valve. This is Becky Han's series looking at multiple trials, and it showed that EOA, mean gradient, and DVI was better in self-expanding valves. So all of this led to the SMART trial. SMART trial was a prospective randomized control study done at 83 sites. It was randomized to self-expanding valve and to the balloon expandable valve. What really was interesting about this study was there was 2 co-primary endpoints. The first endpoint was sort of a traditional endpoint, composite of mortality, disabling stroke, and heart failure rehospitalization through 12 months. The second endpoint was the bioprosthetic valve dysfunction through 12 months, which we will talk a little bit. So the SMART trial results, this is sort of the summary slide. To the left is the first co-primary endpoint, mortality, disabling stroke, and heart failure rehospitalization. There was no difference between balloon expandable valve and self-expanding valve. However, when the second co-primary endpoint was assessed with bioprosthetic valve dysfunction, self-expanding valve had superior results compared to balloon expandable valves. So when you dissect the data a little more in depth, you will find little distinguished information here. And again, these are very small annulus, at least in the Western countries. The mean area of the valve was somewhere between 380. The mean parameter was about 70 millimeters. The most commonly used valve was 26 millimeter valve in self-expanding valve, and 23 millimeter in balloon expandable valve. And when you look at some of the secondary endpoints, this message becomes even more clearer. So the self-expanding valve had mean gradient of 7 compared to 15. EOA was 1.98 compared to 1.5. And severe patient prosthesis mismatch was much, much higher in balloon expandable valve, 9.8%, with also increased rate of total aortic regurgitation in the balloon expandable valve. All this was statistically significant, favoring the self-expanding valve platform. So what was the predictor of bioprosthetic valve dysfunction in balloon expandable valve was a risk factor, and the odds ratio was very high, 8.2. Other factors were BSA and aortic annulus area, but these odds ratios were very, very low compared to the other factor, which was a balloon expandable valve. So self-expanding valve compared to balloon expandable valve in small annulus had non-inferior clinical outcomes, but had superior valve performance with multiple definitions of BVD, and also had less total aortic regurgitation and better QOL based on the KCCQ. So that was the most latest evidence using the SMART trial. And the small annulus has really been the key, but I'm going to shift the gear to the long-term durability of the valve, and we're going to look at two clinical trials that was published over the past 2 years. The first one is the Evolut low-risk trial. We all know the Evolut low-risk trial, but most recently there was a 4-year result that was presented at TCT in 2023. There were a lot of Asian countries that were outside of U.S. countries that were involved in the study. And as you can see, multiple Japanese sites were involved. Some of the implanters are sitting in this table. Just to highlight, this was a low-risk patient. The mean age was about 74. The STS score was 2. So again, this highlights the low-risk patient population. And when you look at the outcomes at 4 years compared to surgery, the Evolut TAVR group had much lower mean gradient of over 20 and much less severe patient prosthesis mismatch compared to surgery. And when you look at the outcomes of primary endpoint, which was mortality or disabling stroke, the p-value was 0.05. And when the p-value is 0.05, you can't really say that there is a statistical difference, but you can see that the delta between surgery and TAVR has really widened over time, which was different finding compared to the other randomized control study. So the primary endpoint now has delta of 3.4% favoring TAVR at this time. The other important factor is that the hemodynamics persistently persisted after 4 years. So so better hemodynamics compared to SAVR was persistently superior in the TAVR side. So some of the key takeaway message from the Evolut low-risk 4-year trial is that there was a 26% relative reduction for primary outcome, which was death and disabling stroke. The curves continue to diverge rather than attenuate, which means crossing, which was seen in the other randomized control study. Also, TAVR had better mean gradients and higher EOAs. However, I'm going to wear a surgeon's hat. The criticism of the trial from the surgical side was that the type of surgical valves that were used, there were 18.7 Abbott valves and Livanova valves. These are trifecta and MitraFlow. And those of you who do TAVRs, those are very, very difficult valves to do valve-in-valve. And those were externally mounted valves, which was known to deteriorate a little faster. And also low use of aortic root enlargement, less than 5%, which has really taken off on the surgical side. Lastly, I'm going to talk about the NOTION trial, which was recently reported a 10-year outcome. This is one of the very few trials that had a 10-year outcome, which randomized to surgery and TAVR. And when you look at the NOTION trial, this was a low-risk randomized control study. But when you look at the age, it was about 80 years old. We're going to talk about that a little bit. And the STS score was definitely less than 4%. But this was a low-risk patient, but a little bit on the older side in terms of patient population. And of course, it used a first-generation core valve. So the randomized arm had 145 that was randomized to TAVR, and then 135 to SAVR. And then the implanted number was 139 and 135 for TAVR and SAVR. The mean age was about 80 years old, as I mentioned, 79.2 in the TAVI arm and 79 on the SAVR arm. STS score was 2.9% and 3.1%. So by definition, this was a low-risk population. So 10-year mortality, again, this was using the first generation core valve. There was no difference between TAVI and SAVR at 10 years. But when they looked at the structural valve deterioration, very interestingly, this favored TAVI over SAVR. So TAVR had less structural valve deterioration. You sort of have to look at the definition a little carefully, though. The structural valve deterioration definition is mean gradient over 20 or increased by 10, moderate patient prosthesis mismatch, valve thrombosis, or endocarditis. When you change this definition to bioprosthetic valve failure, there was no difference between TAVR and SAVR, core valve and the SAVR arm. The bioprosthetic valve failure definition is valve-related death, hemodynamic severe SVD, and aortic valve reintervention. So more clinical definition of that. However, when you think about this, when this trial first started, a lot of people thought that TAVR will have less durability, but this really shows that the durability of TAVR valve is equivalent to the surgical valve. And this used the first generation valve. Since then, there has been multiple reiterations of self-expanding valve. So key takeaway from NOTION trial, TAVR and SAVR had similar mortality at 10 years in low risk but older population. SVD was higher in SAVR valves. BVF was similar between the two groups. We sort of dove in on that here. And TAVR was using the first generation self-expanding valve. Again, I will emphasize that point. Again, wherein the surgeons had the criticism of this was that the SAVR valves that were used, they used 27% of mosaic valve, 24% of trifecta valve, 10% of mitral flow valve, which are not really a frequent use valve in 2025. So the key takeaway from the whole data talk is that self-expanding valve provides excellent hemodynamics and lower patient prosthesis mismatch compared to balloon expandable valve. Self-expanding valve had equivalent outcomes to SAVR at 10 years with better hemodynamics. And these are key component in choosing the first valve in the lifetime management, especially in the durability data that we have. The only data that has 10-year data. So thank you very much.
Yoshi, so before you leave, can I ask just one question? You mentioned during the course of your talk that in the low-risk trial, I think the aortic root enlargement was less than 5%.
Yeah.
What's your feel in the US at the moment? We'll hear about Japan and the Asian countries later, but what's your feel in the US? Has that changed much,
Yes.
and is there a climb in the frequency of that?
We had a session yesterday that I showed a number of aortic root enlargements. It has increased since 2020, 2021. I think it really caught up from the transcatheter side that putting a small valve in has a harm. Now it's about 10% nationally. So, compared to what we were doing in the past, which was less than 5%, it is increasing. However, it's not 20%, 30%.
Okay.
Yeah.
Tony, maybe I can ask you a question to try and make some sense of all these data. What we've seen is, I don't think there's any question that the self-expanding devices have better hemodynamics. What we don't really can't always answer is, does that translate to a meaningful mortality or clinical benefit? So how are we going to make sense of all of that?
Yeah, I think this is really the fundamental question here, David. And if you're a believer in gradients and EOAs, then you're in the right room at the moment, because I'm a believer, but there are still people out there who don't think it matters, which I struggle a little bit with, because it's just common sense that a lower gradient and a better EOA is got to be better for you. And we're only measuring resting gradients here as well. If you put somebody on a treadmill and stress them, their gradient's going to jump up a whole lot more with these smaller EOAs. So it has to, in time, have an impact on heart failure and mortality. And we're seeing that somewhat with the low-risk data with the Evolut system, that we are seeing a divergence of curves as time goes by. And and I think if you do even landmark analyses and take it out to 1 year and eliminate that early surgical penalty, these results are going to have to impact. And it's going to be really interesting what that longer-term data looks like. It's not going to make a difference in the first year or two. It's 5 to 10 years down the track that these EOAs and gradients are going to really matter.
Right. Good.
Yeah, another good point of the SMART trial, I think it's a paravalvular leak rate is less in a self-expanding valve. So that's we believe that balloon expander is better for the paravalvular leak, but now I'm changing mind because the data was nice. So it's also a good point. And also one point is the pacemaker rate. Pacemaker rate is believed to be higher among the self-expanding valve, but the rate is lower than before. So that's a good point, I think.
Yeah, I think I'd just like to amplify that paravalvular leak concept, because it was stated at one of the other sessions yesterday at a presentation of the landmark trial, which was a MyValve randomized trial that had Evolut, MyValve, and SAPIEN. And at the end of the first presentation, there was a dramatic difference in hemodynamics, I think, in favor of the Evolut platform rather than the balloon expandable platforms. But there was a slightly higher paravalvular leak in the self-expanding stents. But it was stated by the speaker that the paravalvular leak was prognostically more important than the hemodynamics, which I thought was a little odd myself. So it's good to see the SMART data showing equivalence or even better paravalvular leak. So that's a good thing. And I guess the other thing in terms of gradients, we locally have some Australian data which I think is powerful data. The National Echo Database in Australia has hundreds of thousands of endpoints of echoes that have been evaluated and show a very, very clear change in outcomes and mortality with changes in gradient, both with native aortic valve disease, but also following surgery and now following TAVI. That's even small increments in gradient are starting to show a significant mortality advantage. So I'm a believer like Tony. I do think the gradients matter a great deal. Any other comments before we move on?
I think the Evolut valve has the most evidence of the low-risk trial and Notion trial and SMART trial. So I think the Evolut valve is suitable for low-risk patient and for the long lifetime management, I think.
Okay, good.
Yeah.
Any questions from the floor? Anybody? Burning questions?
Okay, so before moving to the next presentation, we Japanese has surgical bioprosthesis. Majority of patients received a 90 millimeter bioprosthesis, and number 2 is a 21. So very small bioprosthesis implanted. And Dr. Maeda will mention the clinical impact of the Evolut for TAV-in-SAV. So please talk about it.
Thank you, Dr. Yamamoto. My presentation is focused on the TAV-in-SAV for Asian patients. This is my COI. This is a famous registry, the Vivid registry. The TAV-in-SAV for a smaller surgical valve, especially less than 21 millimeter surgical valve, may be associated with a poor prognosis. So they recommend to surgeons annual enlargement and other related techniques for implanting bigger, larger valves. However, the patient in this registry had the very relatively bigger body size, 1.8 square meter. So I don't understand whether these results to apply to the Japanese patients. So I investigate the early and midterm outcomes following TAV-in-SAV in Japanese AS patients. Sorry, this is a single center study. So 56 patients enrolled, and mean age is 83 years. And you can see the body size is very small, the 1.48. And the high risk ST score was 9%. So this is a cohort of this study. And we prefer to use Evolut series for TAV-in-SAV because they had the very, very small valve, a surgical valve. So the rate of use of Evolut series was 84%. And there were 23% of 19 millimeter surgical bioprocess. So relatively high rate of 19 millimeter surgical valve. And this is the result. The hospital mortality was 0%. And you can see the for 23 millimeter surgical over 23 millimeter surgical valve, we sometimes use sapien valve, but you can see the less than 21 millimeter valve that we usually use 23 millimeter Evolut system, and which resulted in the very good hemodynamics performance. For example, there are only 8% of severe PPM. And this is a brief summary of TAV-in-SAV for 90 millimeter surgical aortic valve. And we implanted 20 millimeter sapien 3 in just only one patient because this patient had a history of TAVR, a special TAVR, which the branch device. So we are afraid of interruption between the orifice of the branch and Evolut. So we choose 20 millimeter sapien valve, but the others patients, we use 23 millimeter Evolut series. So you can see the very, very tiny patient, body size of about 1.3 or 1.2. But you can see we have achieved very, very good hemodynamics because there are no patient with severe PPM using 23 millimeter Evolut system. Despite there were two challenging cases, despite the mitral flow and crown 90 millimeter valve, but we have achieved a very good result, hemodynamics performance after the TAV-in-SAV procedure. So moved on the midterm outcomes that we can, we achieved the very good midterm result. The mortality rate at 3 years was 13%, even in a patient with elderly and high risk cohort. And also, this is maybe my key slide. That's for less than 21 millimeter, the mortality rate was better than for the bigger valve size. This is completely opposite to those of previous report. And also from another classification, the 90 millimeter for 90 millimeter surgical valve, the midterm result was very, very good. There were no mortality in all cause, but not only all cause, but also cardiovascular mortality is very good in 90 millimeter for use Evolut series. So in summary, the early and the midterm clinical outcomes of TAV-in-SAV were satisfactory, and severe PPM after TAV-in-SAV was just 8%, and especially the severe PPM after TAV-in-SAV for using Evolut for 90 millimeter surgical aortic valve was 0%. The early and midterm outcomes of TAV-in-SAV using 23 millimeter Evolut for 90 millimeter surgical bioprocess were very nice. So you can see from one of the review analysis, So in the early phase, the TAV-in-SAV is better than the little ABR. However, in the midterm phase, so little ABR is better than the TAV-in-SAV. So I think this result may be influenced by the severe PPM, because this report includes 34% of severe PPM, and TBT registry reported as 14%, 50% severe PPM, but in our cohort, the 8% severe PPM. So this is a discussion point. I think it is still unknown whether differences in body size or body shape between Japanese and US patients affect the incidence of PPM, and also the whether reduced surgical ABR in Japanese patients is better in the midterm phase. Also still unknown in the first place whether the relationship between PPM and prognosis is correct, especially in the elderly patients. Anyway, the further investigation is mandatory. This is limitations. And in conclusion, even for the small and 90mm surgical valve prosthesis, the early and midterm outcome of TAV-in-SAV using Evolut were very nice in Japanese AS patients. And we have a multi-center TAV-in-SAV registry, so the result will be reported soon. Thank you very much.
Yeah, thank you very much for your very good feedback for the small surgical bioprosthesis for using the Evolut series. And surprisingly, 90mm bioprosthesis, there is no severe PPM cases in your series. Of course, I also provide the Ocean registry data, and the results are very acceptable and excellent. The rates of the severe PPM is quite low than we expecting. So in this context, not only the BSA, but also the elevated mean pressure gradient is very small. So that is the reason why the very severe rates of the severe PPM in our Japanese cohort, I think. Okay, very interesting. So any comments from the discussants or audience interaction is very welcome.
Yeah. In our institution, about 50 cases of the TAV-in-SAV, the severe PPM rate is about 10%. So in our institution, data is the same of the Osaka University, and 90mm surgical valve TAV-in-SAV is no severe PPM. And severe PPM cases are all cases are high BSA. So I think that I totally agree with Dr. Maeda data.
Thank you. Thank you. And of course, we have a lot of surgeons. So according to the no. I would like to ask, because according to the results, if we choose a 90mm bioprosthesis or a 21mm bioprosthesis, the rates of the severe PPM is drastically, not so many high patients. So do we need the root enlargement for such kind of patients? Because the acute result of the root enlargement is sometimes harmful. So based on this data, what do you think about this data?
Yeah,
so
I want to ask the same question to Soji.
I already asked.
Let me add something. So
okay. Okay, please. He has an additional comment.
So sorry, Masa. Because I calculated the post-CT scan after root enlargement patient. The patient had a low coronary height and the valve was not vertical. So I thought this patient is impossible to cannulation the coronary.
Okay, so root enlargement is not so effective for future TAV-in-SAV.
Future TAV-in-SAV and future coronary access.
Okay, you mean, okay.
I mean,
yeah. So two different questions. I think we have to remember what PPM stands for. It's patient prosthesis mismatch. So if the patient has BSA of 1.1, which is smaller than my 10-year-old son, it's not, you put a 19 millimeter valve in, and I think it'll be fine. I don't think that's going to cause problems. To answer Yusuke's point, there has been some concerns with the root enlargement technique, the Y technique. It tilts the valve, and by tilting the valve, when you go in for valve-in-valve, it may not hit both posts. And I think that's something that we're going to learn more and more, because we are doing more and more root enlargements. And valve-in-valve outcomes after aortic root enlargement, I really want to see what the series is going to look like.
I think we are discussing one important change which has happened in last 10 years is, surgical valves such as Inspiris is expandable. So you don't need to fracture it. You can actually expand it at nominal pressure. And when we expand the valve, the height also drops. So I think these are the designs which probably are more relevant in Asia than in Western world, I think, because we can still implant a 19 or 21, but there's a good opportunity to get away from root enlargement. And this is a common discussion sometimes. For example, should I try to squeeze in a 25, which the height of the 25 is tall, sinus sequestration risk is high, and as you mentioned, coronary risk will be high. I rather use a 23, which is great at present, but then I can expand it later and put in a bigger TAVR device. So I think these design changes are going to make our life easy for the patient as well.
Okay, thank you. Thank you for your very good educational presentations and very good point. Yeah.
On looking at those numbers, it would seem unlikely you would need to fracture the surgical valve. Is that an option in Japan? Can you do that, or?
Unfortunately, we don't have it, but if possible, we would like to do it. But based on the results of the low rates of the severe PPM, risk-benefit balance should be considered, of course. But in the near future, we have such kind of technology. Okay.
Tony, any comment about the smaller valves?
Yeah.
And particularly root enlargement. I hadn't really thought about it. I must admit that changing the orientation of the annulus might be an issue for valve-in-SAV after root enlargement. Is that something you've considered?
No, it's the first time I've actually heard of this. So thank you, Vinny, for educating me and understanding this. So our rate of root enlargement remains small, but I guess we're doing so much TAVI these days, we just don't see so much of it. But I think it's the surgeon makes the call about what's the right valve for the patient at the time they're there. So I think that we give them that discretion. But it is going to be interesting how this unfolds. And a small person's going to have a small valve. That's inevitable. So it's not EOA, it's EOA index to BSA is what's the more important measurement here.
Good.
Okay. Oh, no.
I think, I don't know if the audience understands the implication of root enlargement. So if you permit, I can draw something.
Sure, please.
So
we got time.
this is the only symposium with three
No,
people speaking,
you need.
so
And it's better to use a standard mic. Yeah, standard mic is better.
So what Yoshi said is really important. And as we are doing 20% root enlargements, these are going to come back to all of us for TAVR. So essentially, if this is the aortic root and we implant a surgical valve like this, there are two implications. One is relationship with ST junction is relatively constant. So the sinus sequestration risk is very low in most of the patients. And secondly, when you're crossing, you're going to cross like this. Now, when we do root enlargement, the root is enlarged towards in between the non-coronary cusp and the left coronary cusp. So imagine your greater curvature is going to get enlarged I would say, in a manner which we don't want. So essentially, now the relationship of the valve is going to change, and the valve is going to sit like this. Okay, so the ST junction, what I have observed in my practice is if I enlarge it too much, there's a good chance that the sinus sequestration will happen towards the left coronary cusp. and which is, to your point, it comes very near as well, so very risky. But the bigger problem we are going to have is try crossing the valve like this. So what we have found is this is very difficult to cross because it's tilted. And again, the other problem comes is sometimes the anatomy is so tilted, you can't use a tall device. So you have to eventually use a Sapien, for example, or another balloon expandable platform. So these patients, we realized first time when a massive root enlargement was done and patient needed an impeller in the night, it was extremely difficult to put the impeller. So it is really hard to cross when the valve is tilted. So there's a lot of research going on in terms of how much root enlargement, how does it change the geometry, and I think that is going to provide us surgeons also guidance in terms of how much we need to enlarge.
Excellent, thank you. Certainly something I hadn't thought too much about. Okay, well, if there are no other questions, I think we can move on to the third lecture, which is by Vinny Babat, who needs no introduction, I'm sure, even to this audience. He's been very much involved with valves and all matters in terms of valve design. So today's lecture is Design Matters. Vinny.
Thank you. These are my disclosures. So I think the most important thing is this is 10th anniversary, and if we just dial back 10 years ago, you all will agree that the demands were different. And every decade, every 5 years, the patients we are treating is different. Patient expectations are different. Life expectancy is changing. It is, getting longer and longer. And more importantly, disease pattern. So many times we are treating now bicuspid, for example, or valve-in-valve. 10 years ago, 15 years ago, the numbers were very low. So I think the design of the device has to accommodate that, and that's very critical. I always think, this forum, we keep discussing Evolut R, Evolut Pro, another design, but what we forget sometimes is that the delivery system is also important, because if you give me an older valve generation with a new delivery system, I'm sure we can do better, than what we did in 2008. And lastly, the imaging is helping us, and then how much oversize we use, PV leak, etc., for this. So let's look at what are the expectations in terms of valve design. So when we clinicians think of what do we want from a better valve design, so we need, of course, better leaflet durability, leaflet design, stent recoil has to be low, conformability has to be better, so there's less PV leak. And I think stent has to be repositioned or captured specifically for self-expandable valves. From delivery system, of course, this has to be, crimp profile has to be low. If it's 8 French, that is great. And then, of course, we want to cover more range of annulus size, not just for the native, but for valve-in-valve as well. And for delivery system, of course, we need good tracking, reliability, but I think more importantly is stability. Stability for a bigger device, which is a tall device, is very important, because just imagine you squeeze it into 14 French, but when you release it, it's going to become nearly 3.5 centimeter diameter. So all this becomes really critical. So with the Evolut R system, where are we now? And this is just to give some of you who probably were in college when they started, is you can see the evolution of this design. And some of the critical evolutions have been, in my mind, would be recapturability, stability, the design of the frame. In older days, the valve used to dive quite down with the force of the 19-hole expansion. Then, of course, we have seen changes such as skirt. We have seen the profile change as well. And now, of course, the FX has brought in a new dimension. So all these design changes have happened by treating nearly 500,000 patients all across the world. And so physician feedback is always important for the R&D of the company to make the changes. And this has led to a good proven performance, as we have seen in the previous 2 talks already. So what is the new delivery system? And then we'll come back to the change in the design itself. So the tip is better, so you just use it directly through transfemoral access. The capsule is redesigned, and most of you have probably used this system with a single spine now, and a very good stability layer. And this stability layer has been critical, especially in horizontal aortas and more challenging anatomies, where you can reliably implant the valve, because finally it's the usability of the valve and simplicity which leads to our practice. Enhanced visualization is important, and we just discussed one aspect of surgical valve, INSPIRIS, which can be expanded. So similarly now, all surgical valves have better fluoroscopic markers to enable, say, valve in a valve. So similarly now, TAVR designs are also changing. And one of the important changes has been to give us a depth marker. And we can be creative in future in terms of design to facilitate redo TAV and maybe even other implications. So this depth marker is at 3 millimeters. This gives us really good guidance in terms of where you want to be in relation with the bottom of the cusp or a pigtail or whatever you're going to use. The delivery system profile is critical because we are treating a lot of patients. I think in Japan and Southeast Asia, the femoral size is also smaller. So this becomes very important. And again, there is always a compromise between how much you can squeeze the valve and does it affect durability and the strength of the frame. But I think Medtronic has done a really good job in getting a consistent 14 French delivery system for most of their stent frames except the biggest valve. Annulus range, again, wider the annulus range is better because we do have a geographic variation in the world map. If you go to north of Holland or Germany, you're going to get most patients needing a 34 valve. And if you come to Asia, India, etc., you're going to use a smaller valve. So in our practice, we rarely use a 23 in a native aortic valve, but it seems it's quite common in Asia. I think this is really important in having that design to accommodate a wider annulus range. For a valve-in-valve, the range is always wider. That's because the rigid stent frame gives you more stability, and hence the anchoring and the functioning of the valve is tested for smaller annuli. Lastly, but not surely, alternate access is critical. We are treating more and more patients, more complicated patients with alternate access. In fact, I think that we at one point thought alternate access need will completely die off, but in tertiary centers, it's increasing now. So in my center, for example, we have lower threshold of doing a very complicated transfemoral, but we prefer alternate access. And that can be facilitated by the newer delivery systems very easily, not just ergonomically, but in terms of vascular injury as well. So let's come to hemodynamics, which has been very nicely addressed in the previous two talks. But essentially, supraannular design has definitely proven in last 15 years to be better. And Tony highlighted the fact that bigger the EOA, layer the gradients are definitely going to matter, and Yoshi showed that in the slides as well. One of the unique things about this design is that the conformable part doesn't have the leaflets, and then the functioning part is usually not in contact with heavy calcium. And that, if you analyze your own post-implant CTs, you will see that the circularity increases as you go above at the base of the nadir and the top of the leaflets. So this is really critical. The radial force of the valve has been better than the older generations, so the contact with the annulus is better, and hence probably the PV leak, which was discussed before, has been less as well in various new trials. So we know that it does matter, how much ever we think and the way we measure it, etc., but it does matter. I think hemodynamic performance and mortality has been always linked together, and you can see that sustainability of that is really important. 10 years ago, or even 5 years ago, there were presentations which say that durability is great at 3 years. I don't think 3 years is a good durability data. Durability usually is long-term, and we have seen now in NOTION trial, we have got good signal in terms of how these leaflets perform. I will raise my hand first that this is a porcine pericardium, which was never used in any valve, not surgical or TAVR device. I was one of the biggest skeptics of how this is going to perform. So I am impressed by seeing the NOTION results that the durability of this porcine pericardium, and I hope more surgical valves, think of porcine pericardium as well. I'm going to show you a really old picture of our case, which is on the right side. This is how we used to do a valve-in-valve, and you can see if we implant it deeper, we didn't get any benefit. This is just to highlight that the recapturability has been critical in improving the valve-in-valve results. And I think in Japan, especially in Southeast Asia, where the valves are smaller size, ideal implant is important, and we should make effort to do this implant, which probably reflects why your results are so good because of the depth of implant. Durability data, I think, again, I highlighted already lower gradients, lower UA. I'm a simple person. I always think that critical aortic stenosis is 1 centimeter square, so it is better to start at 2.5 rather than 1.6, because it's just going to take me more time to come back to 1. And it's a very simple way of saying what is the gain in the area as well. And I think supraannular platform, at least the geometric opening area and UA measured by Becky Hahn's paper has shown that before. Dr. Kaneko already showed these results, so I'm not going to highlight this, but again, this has been shown critically in the randomized trial. Lastly, but not surely, I think the imaging has been critical in development of this platform in terms of reducing the PV leak. PV leak skirt, of course, has helped a lot. So enhanced sealing, in my opinion, has been achieved because of better skirt, better imaging, and of course, use of post-dilatation, which is also critical. And I would appeal to all of you to try and get the best result on the table so that your patient benefits from durability of this device. Again, this has been highlighted in variety of trials. This is just to show you that with Evolut Pro and Pro Plus, the PV leak incidence is, significant PV leak is nearly 0. And lastly, but not definitely, is the commissure alignment. When we published the first paper on commissure alignment, probably nobody understood, including us, what the implication will be. Our focus was mainly on the blood flow and the coronary flow as well, because as you know, surgical valves are all commissurally aligned. And there's an old literature in mechanical valves on orientation of greater orifice and smaller orifice. But slowly this has become very relevant because coronary access is very critical. And as you know, that the FX system allows you to do that in a very reliable way. And I'm sure some of you or most of you have already used it. With the cell system, which is bigger, you will be able to access the coronaries, which is critical in that small percentage of patients where coronary access is needed, either in elective or emergent time frame. So commissure alignment can be reliably achieved, and Dr. Tang has already published on this subject. Lastly, but not surely, I think, is the implantation technique. And I need not go into the detail. I think everybody practices that. I think standardization of every technique, stable delivery system, reliable platform, understanding of oversizing has all led to, I think, a very refined result. And this has led to all the benefits we see in terms of not just the discharge, but also PVL and permanent pacemaker. This is just a snapshot up to, I would say, in the last few years that the pacemaker rates have been on lower side and definitely in single digits in a lot of centers. So to summarize what has changed, and I would go back to the first slide, is these all were the issues with TAVR devices, right? Stroke, pacemaker, PV leak, coronary obstruction. And I think with the newer designs now, we are taking care of most of it. So technically speaking, you can choose, majority of patients will benefit from this platform, not just for immediate result, but for long term as well. Thank you.
Thanks, Vinny. Appreciate it. A couple of questions, I guess. One about selection criteria and anatomy, I suppose. And in terms of device design, in the early stages, bicuspid valves were taken out of the inclusion criteria, but they've been included in some, including the SMART trial. The results look pretty good. in comparing trials, it's important, I think, to understand differences in selection criteria, because often the very nodular, craggy, calcific lesions are excluded from some trials, and bicuspid valves are sometimes not. Are there anything you would say about anatomy that would make you concerned about using this device?
Absolutely. So I think in our early experience, if it's a very horizontal aorta, just as a morphological feature, we would have difficulty implanting a tall device like this reliably, other than implanting it deeper. But with the FX system, we have found that it is actually easier to get a reliable depth and implant. That's one thing. The second thing is conformability around calcification. And slowly and surely, the philosophy is changing as well in terms of getting optimal expansion on the table. And this has been our practice now, that no patient should leave with anything more than trace of mild PV leak. We have become smarter in terms of selecting which bicuspid morphology will benefit as well. Now, there are some extreme patients where surgeons don't want to operate because they are very high risk, but it's a very calcified raphe. I think this valve definitely behaves better in terms of giving a decent result.
Good, thanks.
Yes.
One for the Japanese crew then. There's a discussion about access, and we've talked about very small body surface areas. Do you often find that the arterial access does not allow a femoral approach?
Yeah, so I think for Japanese it's the same as US people, but we are treatable from transfemoral maybe 95%. So it's Evolut can be passed even in 5 millimeter access. So we can manage.
There's not many you'd have to exclude because of the femoral size.
Exactly. Yeah.
One question for Bini, can I? Okay.
Please go.
And based on your flow analysis, sometimes the patient is, if we adjusted the commissure alignment, sometimes the coronary alignment is bad. So which is better in this situation, to align to the coronary or commissure?
So usually if the valve is tri-leaflet, as we surgeons always see on the table, the non-coronary cusp is always a bit longer, or in terms of length. So I still think the difference between coronary and commissure alignment is very marginal in terms of real benefit. Now, it might change in a bicuspid valve, especially type 1. So in type 1, it's not unusual that your one coronary is more near the commissure and the other coronary is in the center. And I think these are the patients where we prefer to then do coronary alignment, provided this patient is on the younger side. Because I think if the patient is very old, it's probably not that important in terms of increasing the complexity of the procedure.
Good. Comments? Yeah, okay.
I have one question. When I think about the lifetime management, the TAV-in-SAV strategy is one of the options for the lifetime management. The Evolut valve is the risk of sinus sequestration is important for TAV-in-SAV. The Evolut valve is higher rate of the risk of sinus sequestration compared with the balloon expandable valve. What valve do you use the low risk patient and a younger patient?
You're asking a surgeon? I use surgical valve. There's no risk, no complication. But I think, jokes apart, I think this is very important. And this is the question for all of you, actually, that should we start thinking of getting the best result of the first procedure, or we should maybe compromise a bit to start thinking of the second procedure? Now, I think this is a challenge. And my simple formula is two things is life expectancy and valve durability expectancy. I'll give you an example of valve durability expectancy first. So chronic renal failure dialysis is not uncommon, especially in Japan. So these patients, you implant a biological valve, they are going to come back, whether we like it or not, very fast, because these valves calcify faster. In these patients, we plan and implant lower. If we don't do that now, in 3-4 years' time, when they are older and sicker, me and Yoshi and Dr. Kochimeda, we will have to explant these valves, which is not ideal. So I think in chronic renal failure patients where I feel the valves are going to come back faster, whichever platform I use, I definitely use it so that I don't shut the door for the next procedure. But for younger patients, this is very challenging at present because the moment you lower the implant, your pacemaker rates are going to go up. And that's a reality. There is no compromise between the two. So in our analysis, which has been now published for both balloon expandable and self-expandable, the self-expandable valves with the current practice of implanting higher definitely has around 12 to 13% higher chance of needing something excessive like basilica, leaflet modification, or a very high risk of coronary. So that's the next challenge for this platform or any tall platform. How do you modify the design to accommodate? So I don't have the answer for it other than implant lower, but maybe in future we are going to see some elegant solutions for that.
I would like to ask, I'd like to discuss in deep depth, when considered the lifetime management and the future TAV-in-SAV procedure, sometimes we have not so many experiences. So, but we estimate the risk of the future TAV-in-SAV sinus sequestration using post-procedure CT scanning. And some investigators mentioned the risk of the future risk of the sinus sequestration after the Evolut series in Japanese cohort. 1/3 or 2/3 patients has a risk, but I think this is overestimated because it is a virtual risk assessment. It's not real. So actually you have a lot of experiences for the TAV-in-SAV procedure using Evolut series. So do you think this post-CT scanning risk estimation is overestimated or not?
So as I said, it's the best guess at present. And however, we have now 4 registries in the world which are focusing on predicted versus observed. And that's going to be very important. So what has been missing up till now in TAV-in-SAV is good planning and execution. All of us have been doing cases on what we feel is okay. And sometimes, we saw it in the session yesterday. You want to implant here, but it ends up lower or higher. So I think systematic planning and then doing a CT scan later is going to, the early signal, if you ask me, is that we are pretty accurate in measuring these dimensions now. So what I mean by that is if we predict this is going to be 2 millimeter, it generally ends up at 2 millimeter if we implant it perfectly. So I think this is probably not far from reality.
Okay, so probably, yes, you have a lot of, data, actual data.
I don't know about that. We're still learning about this, but the only combo that really makes a difference is when you have a tall valve and you put a short valve in, right? Which happens very frequently, and I think that positioning really will make a difference. So I think you have to put that in consideration, and it's very difficult for us to simulate everything. So what we do is, we punt it to the companies. So now there's DASI simulations. And if we have any concerns, we will have them virtually put a valve in, and they will tell us the coronary obstruction risk. It's the report is very detailed, and it will tell you exactly where to position the second valve. And we actually do it for a young patient on the first, before the first TAVR valve to see where we should be placing it. And that will give us a lot of info.
Thank you.
Absolutely.
Yes, so very good discussion. Okay,
Thank you.
very much, Vinny. So let's move on to the next presenter. Okay. So the last speaker is Yohei Ono. Thank you for coming.
Thank you. Good discussion.
Yeah, and his title is The Importance of the First Valve, Commissure and Coronary Alignment Post-TAVR. Please start.
Thanks, Masa and everyone. I'd like to share my talk regarding importance of first valve, commissure, and coronary alignment post-TAVR. So this is a famous study from Philip General and their colleagues that predicted future TAV-in-SAV growth in the US model. So it's easy to predict that the volume of valve-in-valve itself grows, but mainly the TAV-in-SAV. TAV-in-SAV grows, but gradually, whereas TAV-in-SAV grows rapidly. So actually, based on this same Monte Carlo simulation, we have predicted what's going to happen in our population in Japan. So we basically follow the same model, and the prediction was as follows. So obviously, the whole valve-in-valve procedure will grow over the years. Likewise, the US trend, the TAV-in-SAV gradually increase, whereas the TAV-in-TAV rapidly increase. So in the future, 2035, this is completely a prediction, but the TAVR market grows, obviously, and the valve-in-valve has a bigger proportion than current status. So in order to prepare well in this circumstance, I think the index procedure is more important than ever. So what we need to achieve is the commissural and coronary alignment, and as we discussed in the previous session, the appropriate depth for each patient. There's as you may know, this aligned TAVR consortium led by Gilbert and colleagues. There's now a kind of definition how much we are aligned or misaligned based on the post-procedure CT scan. And usually, if the commissural alignment is achieved, in majority of the cases, coronary alignment is likely to be achieved. But as we discussed previously in bicuspid and some anomaly patients, not all the coronaries comes from the center of the cusp. Some comes quite close from the commissure. So this is still a challenge in our practice. So why do we try to achieve commissural alignment? Obviously, there are several reasons. The immediate outcome could be coronary access, highly likely to achieve coronary access if we appropriately align the valve. And we just talked about the redo procedure in the future. If the commissure is right in front of the coronaries, even if we have a leaflet modification, shortcut, whatever tool we have, it will not make it as for the coronary flow or protection. And some report has provided some insights that even the valve function itself may impact based on this alignment. And we have accumulating evidence that it may potentially decrease the incidence of halt if we can achieve the commissural alignment. So therefore, we performed this study with Guy and presented in late-breaking clinical trials in London Valves. The idea was using this latest platform in Japan, Evolut FX. We still don't have Evolut FX Plus. 126 patients, average age 81. So we basically enrolled consecutive patients prospectively. And immediately after the valve implantation, we tried for coronary cannulation, both left and right. So the definition of successful coronary cannulation was whether we achieved within 10 minutes. We just followed the previous literature. And for the left coronary, 100%. Whereas for the right, as expected, a little bit less, but still good numbers, 97%. Based on the post-procedure CT scan, majority of patients achieved commissure alignment, a little bit less coronary alignment, but good numbers, including bicuspid patients as well. The coronary cannulation time based on the post-procedure CT scan, whether the patient achieved coronary alignment or not. Obviously, if the patients had coronary misalignment, longer time, coronary cannulation time had taken. And we were able to identify some anatomical factors that was associated with suboptimal coronary cannulation, which was left coronary height. Obviously, if it was lower, it took longer time. And coronary misalignment was very important for both left and right. So I would like to share our patient here, 78 years old male. We can say relatively young patients, maybe not for you, Yoshi and Vinny, for the US patients. Presented with symptomatic severe AS, two-vessel disease, left for the left, LAD and circ. Had some comorbidities, mild kidney dysfunction, elevated BNP, complete right bundle branch block. But patient was independent, well, active. ECG has shown complete right bundle branch block. The echo showed high gradient severe AS. The movie is not working. Peak velocity 4.7 meters, AVA 0.5, DVI 0.13. So quite very severe AS. The coronary angio is shown here. A very tight stenosis in the proximal LAD. So please consider what kind of treatment should we offer in this specific patient. So diseased circumflex. And a good collateral flow from the right. The CT scan shows here relatively big annulus, perimeter 79.8, 79.5, wide sinus of Valsalva over 32, 33 millimeters in width. ST junction is also wide, nice and wide, 28. Very bulky, thick calcium in 3 leaflets, tricuspid valve. Left main height was 16, whereas right was 19, quite high. And the member septum was 6. So based on these anatomy, clinical backgrounds, which valve should we implant, or which valve are you going to use? So maybe based on the coronary artery disease and right bundle branch block, maybe it will be easier to implant balloon expandable platform. But my center is a little bit weird that our pacemaker rate is lower in the self-expandable platform. So considering that and considering the durability of the platform, life expectancy of the patient, we have implanted Evolut FX29. Exactly what Vinny has mentioned, we were very careful about the depth of the implant. So this was the final shot. Mild PVL, but the depth was just as we intended. Post-procedure CT scan, no complete AV block. Post-procedure echo showed good EOA, hemodynamics, trivial PVL. And this was quite remarkable, the post-procedure CT scan. Although the patient had very severe, thick, bulky calcification, we performed actually post-dilatation quite aggressively. And the valve was expanded quite well, as you can see here. And as for the commissure of this newly implanted Evolut, was shown in this blue dot. And the original commissure was shown in this right. So it was completely aligned in terms of commissure alignment. And this patient had normal origin of the both coronaries, right and left. So both left and right coronary alignment was achieved as well. So after the post-procedure CT scan showed, since the patient had wide sinus of Valsalva, wide ST junction, adequate coronary height, so on, so future TAV-in-SAV, considering this aligned valve, could be feasible. And we were able to also plan for the post-procedure PCI. So it was quite a tough lesion, but this radial approach, right 6 French, Ikari right 1.5 fit very well, good backup, and we implanted 2 drug-eluting stents, and patient recovered very well. So as was the discussion from the previous talk, we need to consider both durability of the transcatheter heart valve and repeatability for future potential redo procedure. Both are extremely important. So we need to, tailor from each patient to patient. but I think based on the good data that Yoshi has presented, I think durability is more predictable and important for this kind of patients, not very young patients. Index procedure is the most important, with optimal implantation depth and orientation. Post-coronary Evolut coronary access can be achieved after contemporary Evolut implantation. Thank you very much for your attention.
Thank you. Thank you very much. It's very excellent on the education. And could you please show the this smart screen slide? Because why the coronary align and commissure align is so important? The coronary artery is sometimes located in not 120 degree. Sometimes coronary ostium coronary is shifting. And this is a very important thing. If we align the commissure alignment for such kind of patient, the commissure alignment seems to be good, but the coronary alignment is bad. And even after the basilica technique, if the commissure part is in front of the coronary arteries, even using the basilica technique, sinus sequestration, the risk of the sinus sequestration still remain. And everybody knows the long-term durability data was excellent for the Evolut series, but why we don't use the Evolut for such kind of younger patients? We obviously overestimated the risk of the coronary obstruction, but we should pay attention for that reason. So the commissure and coronary alignment is so important, so that is the reason why he presents. And what do you, any technical improvements for such kind of very difficult situation? If we align the commissure, the coronary alignment 0%, it's a disaster. So what kind of solution do we have?
I think we need to learn from you that you're working on the simulation, and as Yoshi mentioned, I think other, like, let's say DASI simulation, those kind of things may guide us a little bit further in order to more improve the commissural and coronary alignment in some complex anatomies. Vinny?
Thank you. Yeah, okay.
So I think this is very important, but we have to remember that cusp overlap technique allows you to do commissure alignment. To do now coronary alignment is another complexity during the case. So I think we need to be careful about it, because if we try and do that, it might change, of course you will have to change the fluoroscopic view to achieve that. And that may then complicate the depth of the implant. So again, I think we need to understand the implications and maybe how to use not just the pre-CT analysis, but then make that clocking, based on the CT. So you check your depth in one view, and then now go to another view and then misalign it a bit so that it aligns properly. I think this needs a bit of thought process, but I'm pretty sure one can come to that. But we have to keep it simple.
But Vinny, in order to do that, do you think we need a dedicated device that we can rotate at the ascending aorta? Ideally.
So with a lot of new platforms as well, this has now become mandatory thing. And one thing we have seen is that if you align it before engaging in the aortic valve, the alignment changes. So I think what is critical is, the way I'm just thinking while your talk is going on is, we do the cusp overlap, we align to the commissure, and then we misalign it as we start implanting, and then check in another view that it is misaligning in the right direction. And I think that may be the best way to do it. Mm-hmm. And Masa can try it and tell us next year.
Also, but also additional comments. Okay, Kaneko, please. Okay.
You can go ahead.
Okay. So yeah. Even we have the if the technology has the valve rotated in the ascending artery, it is very important and very easy to align. But how degree we align, and it's very difficult. So a kind of solution to fusing the CT image or to identify the correct position, the align.
What degree in which projection, right? This combination matters.
Thank you.
Yeah, I think
Okay.
that CT angle is
Yeah.
going to be important. And as Vinny said, I think you are going to start with the coplanar, not coplanar, the cusp overlap view, and then switch it to that view. And I would ask the Medtronic to come up with, technique to pre-calculate it for us, and then just change it to that angle and then implant it. I think we just have to emphasize the importance of that. So all of those can be calculated with a CT scan ahead of time. And we should have that information before going.
Yeah.
I think standardizing practice always helps. I think fusion imaging, I call it confusion imaging. So maybe it will change with time, but it can again increase the burden, right? We are thinking of a standardized practice, and I think there will be an easy solution for this.
Okay, thank you. So, Yusuke, you have a comment?
So
Thank you.
our colleague, Dr. Higami, he's making the software to align coronary alignment to using a pre-procedural CT scan. So maybe innovation with such kind of application will be good for this matter.
Sure.
Yeah.
Yeah. A little bit confidential. No, just a joke. So okay. Okay. So
Good, Tony.
I think the companies need to help us with this, or we need some kind of software application to do it, because in a busy day you might be doing 4 or 5 TAV and be sitting there and trying to work out all the nuances of this. I think you just really want a very simple formula where you've had your CT analysis and it says, all right, this is the valve you're going to put in and this is the way you're going to orientate that valve. This is where your dots are going to be, and you just need a picture in your head when you go into the room and do your case, and you go, okay, this is where I need my markers in relationship to the cusp overlap view and then the 3 cusp view. And I think that's the way it's going to go. But that was a great case, mind you. There was so many things to talk about there. You've got advanced coronary disease. Do you fix the coronary disease first, or do you fix the coronary disease at all? There's a right bundle branch block. Does that tilt your choice of valve? And some of those patients, we might do a valvuloplasty first, fix the coronary disease, and then come back and do the TAVI later on. Because then you don't have any issues about commissural alignment. You've done it that way. And so you're doing 2 procedures, but you've done 2 procedures anyway. So I'm not sure I know the right or wrong answer to that, but I do know that we do need to be fixing the coronary disease, I think. I think the evidence has become stronger around the fact that you do need to fix major coronary disease like that patient had, particularly when they're under 70 and if they're 90, it's a little
Especially
different.
the young ones. Yeah.
Yeah.
Certainly. Good. Any questions from the floor? We're getting close to time. We have time for a question or 2 if there are any. If not, sure.
Ui.
You made a very important comment actually, because these are the cases, if there are 10 cases with AS and coronary, you're going to have different decisions in different patients. Now, of course, before the FX and commissure alignment, you would have changed your valve choice for some of those cases. But now you have the comfort, as Yohesh showed, that you can access the coronaries. And so you can do commissure alignment to make it easy. So I think he stuck to his first choice of valve and didn't change it. So I think the design matters, which was my talk. I think as achieved, looking at his case, all these changes of this design, which every design change takes 3 years, has really benefited that patient because he's comfortable using this particular platform and he didn't have to change the valve choice.
Yeah. Excellent.
To that point, it's design change, as you say, takes a long time, Vinny, but technique change does not take very long at all. And so if we decide we believe in cusp overlap view, then we can adopt that very quickly. There's no patent on cusp overlap view, I don't think.
Mm-hmm. Okay, I think we should close it for lunch.
Okay, so thank you very much. I would like to summarize the first presentator, Tsuyoshi Kaneko, summarize the latest evidence of the notion or Evolut low-risk trials, and we have a lot of knowledge from the very good, excellent durability data. Everybody knows, okay. And also, the Dr. Kenichi Maeda mentioned the TAV-in-SAV procedure, very low rates of the severe PPM, even using the 90 millimeter bioprocesses, very low rates of the severe PPM. And Vinny Baba talks about the design matters. We have a lot of knowledge. We learned a lot of knowledge from him. And last comment was Yohei Ono. He mentioned the importance of the commissure alignment and coronary alignment to consider the future TAV-in-TAV procedure. Okay, so in considering the lifetime management concept, it's very important. All of the presentators' comments are very helpful. Thank you very much.
And I'd like to thank all of the speakers, particularly for coming, the panelists for coming, and you, the audience, for being here for the hour and a half. Thanks. Time for lunch.
Thank you.